Bismillahirrahmanirrahim. We have already discussed approach to pain abdomen. We have discussed general symptoms of abdomen, gastroenterology, including genitourinary system, and then we discuss specifically pain abdomen, how to approach to the history of pain abdomen, then how to examine the patient presented with pain abdomen. Now, uh, we will be discussing about how to construct a differential diagnosis from that information. Uh, what history we have now and what examination findings we have now with us. Based on these two things, uh, we should know how to construct a differential diagnosis about abdominal pain. This is a very important area. This is the area where most of the doctors find difficulty. They have taken history, they have examined the patient, but uh, integrating all these informations and constructing a differential diagnosis, this is a tricky procedure, and this is if we can say it's an art. How to develop the differential diagnosis, this is what we will discuss today, inshallah. In terms of abdominal pain, I have classified abdominal pain into three broad categories based on the location of abdominal pain. One is diffuse abdominal pain, second is, if you can say, upper abdominal pain, and third is lower abdominal pain. On anatomical basis, we classify the abdomen into 9 quadrants. We have studied in anatomy, and later on most of the books localize the pain in 9 quadrants. But on the practical ground, what patient told us and what we examine the patients, in order to ease the things, I have classified these 9 quadrants into 3 general quadrants. Either the patient has diffuse or perimbilical abdominal pain, or the patient has upper abdominal pain, or the patient has lower abdominal pain. This will ease the things in your mind. So if the patient presented to you with diffuse abdominal pain, and you have taken the history of that patient and you have examined that particular patient, and you have these findings, like if you look at the patient, the patient has very toxic look, he is sweaty, he is pale, and he is very anxious or drowsy or confused, and on examination patient has tenderness and guarding as well. Vitally he is unstable, he has tachycardia with pulse rate of more than 100, blood pressure less than 100 systolic, GCS of about 12, 13, urine output is marginally reduced, and on auscultation the patient has absent breath sounds. That patient is a candidate for peritonitis. This is the first thing. We have discussed earlier that one of the important thing while approaching the patient having particular symptom is to rule out what's emergent cause. Let's rule out what's emergent cause. And peritonitis is the most emergent cause or etiology while approaching the patient with someone having abdominal pain. So if you find these findings on your history, the patient has severe abdominal pain that is diffuse, he is looking toxic, he has tenderness, he is guarding, his vitals are pretty much unstable, and he has absent bowel sounds, that patient might be having peritonitis. Immediately order plain X-ray chest and abdomen erect. What will you see? You will see air under diaphragm. You will see air under diaphragm, specifically on the, you have to see on the right hemidiaphragm, because on the left side you have gastric bubble that will confuse with the air under diaphragm. So if the patient has free air under the right hemidiaphragm, that patient has peritonitis or perforated discus. Second, you will order the ultrasound abdomen for free fluid, that is fast scan, or if there is some concealed perforation but the patient has severe abdominal pain, or you are in suspicion that there might be peritonitis or not, then order CT abdomen. So what might be the underlying cause? The patient might be having bowel perforation, DU perforation, typhoid, tuberculosis, traumatic malignant. Above three are very common in our society. First is duodenal perforation. If the patient has preceding history of epigastric pain, retching, vomiting, nausea, then the patient might present to you now with duodenal ulcer perforation. Secondly, typhoid perforation. This is also very common because we have uh, very we have unavailability of medical services in our remote areas, even in urban areas as well. So most of the times patient didn't get adequate antibiotic treatment of typhoid on time, and they present on second by the end of second week with typhoid perforation. Third is tuberculosis. Tuberculosis is very common in Pakistan, both pulmonary and extrapulmonary tuberculosis. So tuberculosis perforation is also came across as a differential of peritonitis as well. Then traumatic, if the patient present to you with trauma, polytrauma, uh, abdominal trauma, the patient is might be having peritonitis, and then the lastly malignancy. The patient has very prolonged history of abdominal pain, wasting, cachexia, anorexia, and now presented with surgical abdomen. That patient might be having peritonitis as well. Then intra-abdominal hemorrhage. That patient might present to you with peritonitis as well. Third thing that I haven't mentioned here, that is subacute bacterial peritonitis, SBP. The patients who have abdominal ascites, especially the patients with transudative ascites, have very high risk, are on very high risk of subacute bacterial peritonitis, SBP. So if the patient has history of chronic liver disease, or the patient has underlying history of ascites, and now he presents to you with pain abdomen, fever, toxicity, tenderness, gardening, that patient might be having SBP. So this is the first differential that you have to keep in mind while approaching the patient with diffuse abdominal pain. Second thing, bowel obstruction. So if the patient has very crampy, diffuse or periumbilical abdominal pain, which comes and goes, means colic in nature. So crampy, colicky periumbilical abdominal pain, along with vomiting and absolute constipation. Patient tells you that he hasn't passed stool or flatus since like 12 hours, 24 hours, 1 day, 2 day, and on examination you find very exaggerated bowel sounds. Then this patient might be having bowel obstruction. So this is again a surgical emergency that needs urgent surgical care. So we will again order plain abdominal X-ray direct, or if it's not conclusive of finding the underlying cause, CT abdomen pelvis. So what the underlying etiology you are suspecting here? Adherence, volvulus, malignant obstruction, strangulated hernia. These are the four most common causes of this bacterial obstruction that we came across: adherence, volvulus, malignant obstruction, strangulated hernias. Then third thing is, this is not very much common if we are discussing against peritonitis or bowel obstruction, but it's not that much uncommon, and it's a very dangerous thing if it's missed. So third thing that we have considered, if the patient presented with diffuse abdominal pain and he looks very toxic, drowsy, uh, and having hypotension, is abdominal aortic aneurysm, especially ruptured abdominal aortic aneurysm. Most of the times abdominal aortic aneurysms are asymptomatic, usually patients having some abdominal or back pain. First symptom of abdominal aortic aneurysm might be thrombosis or embolization of distal side, that the patient having aneurysm in the abdominal aorta might present to you with digital ulcerations, digital ischemia, digital gangrene of the distal fingers of feet. Uh, Such patients with abdominal aortic aneurysm sometimes present with ruptured abdominal aortic aneurysm. These patients have acute abdomen with pulsatile mass or hypertension. So what will you order? You will order ultrasound abdomen with Doppler studies or CT ortogram or CT angiogram. If the patient has ruptured abdominal aortic aneurysm, it's a surgical emergency. You have immediately refer the patient to the OR and call the surgical team on duty. Then next thing is intestinal ischemia. This is the fourth red flag differential that you have to rule out, before going to the benign causes. It's a very tricky diagnosis. Patient usually present with severe perimbilical or diffuse abdominal pain. One thing that has frequently mentioned in the books is that pain is out of proportion to the physical findings. As on physical findings, you will not find any guarding, you will not find any rigidity, but the patient has very severe abdominal pain. Vowel sounds might be normal. However, sometimes that patients have bloody diarrhea and they look toxic. Surely they are vitally unstable. Acute intestinal ischemia will present with diffuse abdominal pain or perimbilical abdominal pain that is severe in nature, out of proportion to the physical finding. Sometimes it's associated with bloody diarrhea. The patient looks toxic or vitally unstable. So what will you do? You will order a plain X-ray abdomen erect that might show an diaphragm if that ischemic gut is perforated. Blood workup will show leukocytosis and some metabolic acidosis. However, diagnostic test is CT angiography. You have to order the CT angiography if you have high suspicion for intestinal ischemia, because it's catastrophic if you wait. Patient might die with sepsis or toxicity of gangrenous gut. Risk factors, especially ask about the risk factors if you are suspecting acute intestinal ischemia, that is, the patient has preceding atherosclerosis, low cardiac output state, recent MI, cardiovascular disease. These patients are high candidates of presenting with acute intestinal ischemia. Then chronic intestinal ischemia, it's a bit of a long-standing disease. Patient usually comes with onset of abdominal pain after 1 hour of eating meal, half hour to 1 hour of eating meal, and pain gradually increases and then subsides over few hours. Patients have concomitant weight loss and cachexia because people avoid eating in order to prevent the pain. So again, how will you investigate it? You will order CT angiography. Typical patient is smoker with atherosclerotic vascular disease. So chronic intestinal ischemia, patient present with crampy periumbilical pain that usually starts 1 hour after taking meal, not immediately, not within 15-20 minutes, usually half hour to 1 hour after taking meal, and the symptoms subside over next few hours. Patients also has some weight loss because people avoid eating in order to prevent pain. Then occult malignancy. This is again very grave diagnosis that you have to consider if the patient has very long-standing pain or refractory pain to usual therapies, and the patient is not responding to your other first-line diagnosis or benign diagnosis, like patient with pancreatic cancer has severe epigastric or periumbilical pain. Patient with renal cell carcinoma might present with flank pain or abdominal mass. The diagnostic test of choice will be CT abdominal pelvis with contrast. Then these differentials are pretty much less common, but again they are very grave in nature, so you have to consider them as well. If you find any associated features, we have already discussed in approach to abdominal pain that you must complete your history by asking questions about connective tissue disorders and vasculitis, as the patient presented with SLE might be having sinusitis that cause pancreatitis like picture. Vasculitis patients usually present along with inflammatory bowel disease, especially Crohn's disease. Antiphospholipid antibody syndromes usually have associated abdominal pain. Patients with polyarteritis nodosa have abdominal pain. Church-Strauss syndrome might present with abdominal pain. Patients with Hinault-Schall and purpura are usually presenting with abdominal pain and bloody diarrhea. And Behçet's disease, these patients have abdominal pain along with oral and genital ulcers, uveitis, arthralgias, and arthritis. So patients with connective tissue disorder with vasculitis can present with abdominal pain of variable characteristics, variable quality, but you have to consider connective tissue disorder and vasculitis while approaching the patient, especially if other causes are ruled out, or if you find a very specific symptom in history of that patient that favors connective tissue disorder. Then metabolic causes, if you haven't find any acute causes or any surgical causes while approaching the patient, as we have ruled out peritonitis, bowel obstruction, ischemia, then consider metabolic causes, because these causes can also be catastrophic if missed, and they can be diagnosed very easily. Like patient with diabetic ketoacidosis, they present with diffuse abdominal pain, vomiting, acidotic breathing, and high blood sugar level. What will you do? You will check the blood sugar level. If they are high, send ABG, serum ketones, and serum electrolytes. Usually the underlying cause is type 1 diabetes mellitus, as these patients have absolute insulin deficiency that leads to ketogenesis and diabetic ketoacidosis. Adrenal insufficiency, acute adrenal insufficiency, such patients can also present with diffuse abdominal pain, vomiting, hypertension, hypoglycemia. How will you suspect that? If you can ask the patients about drugs. If the patient is taking steroids and he is not taking steroids from last few days, he might presented with acute adrenal insufficiency, or the patient has underlying Addison's disease and he is not taking these medications, or he is undiagnosed and now present with some triggering factor like infections that leads to acute adrenal insufficiency, and these symptoms and findings. Hypercalcemia can present with abdominal pain of variable variety. Hypercalcemia causes peptic ulcer disease that leads to epigastric pain, nephrolithiasis that causes flank pain, pericarditis that causes severe epigastric pain. While approaching the patient with variable or diffuse abdominal pain, also keep hypercalcemia in the mind. Most commonest cause of hypercalcemia is hyperparathyroidism, and second commonest cause is malignancy, where hypercalcemia presents either as paraneoplastic syndrome or due to direct body metastasis of malignancy. Then these are very least common causes, but you have to keep these in mind as well. Acute intermittent porphyria, it's a very rare disorder where the patient present to you with episodic abdominal pain that is very severe, and the patient has also neuropsychiatric symptoms. He might have some agitation, some irritability, some abnormal body movements, and some changes in his memory, his behavior, his personality, and he might present to you with episodic severe abdominal pains. That patient might be a case of acute intermittent porphyria. Usually post-pubertal women are the common population where we can find acute intermittent porphyria. What will you do? You will order urinary porphobilinogen levels during acute attacks. Sickle cell crisis can present with pain abdomen. Then heavy metal poisoning like lead, cadmium, arsenic, mercury, that patients can present with abdominal pain, neuropathy, heavy metal exposure. If you find any chemical, any environmental, any occupational exposure while approaching the patient, then consider heavy metal poisoning as well as a cause of diffuse abdominal pain. Then lastly, familial Mediterranean fever. Again, it's a very rare, not very common in Pakistan. I haven't seen anyone with familial Mediterranean fever here, because it's more common along the Mediterranean lineage, ancestry like Turkish, Arab countries, where the patients presents with bouts of fever, high-grade fever that lasts for 1 to 3 days, along with abdominal pain, monoarthritis that specifically involve knee more than ankle, pleuritis that causes severe chest pain. These patients usually have some genetic predisposition, or they are having Mediterranean ancestry. We have a few diagnostic criteria for familial Mediterranean fever, but if you find this constellation of symptoms and physical findings, you can suspect familial Mediterranean fever. Colchicine is the drug of choice first line for patients with familial Mediterranean fever. Angioedema, again, it's a very rare disorder. Angioedema patients can present with swollen face, hands and feet, along with abdominal pain because of swelling of gut, angioedema of the gut. So you can suspect angioedema in that patient specimen. Irritable bowel syndrome, IBS. This is diagnosis of exclusion, diagnosis of rule out. In a patient's presented to you with diffuse or peri-umbilical abdominal pain that is sometimes crampy in nature, and along associated with bloating, and pain is relieved by the bowel movement, and the patient has changes in the number of bowel movements or stool consistency, means diarrhea alternating with normal stool, or diarrhea alternating with constipation, or constipation alternating with normal stools. So we classify irritable bowel syndrome depending upon the predominant symptom. If it's diarrhea, it's irritable IBS diarrheal type. If it's constipation, if it's IBS constipation type. So you will find a triggering factor like stress or overeating, but one of the major thing is that you have to rule out all the organic causes before proceeding toward the diagnosis of irritable bowel syndrome. So these are the differential diagnoses of diffuse abdominal pain. The important thing that you have to keep in mind if the patient present to you with diffuse abdominal pain is to rule out the surgical abdominal patient. Is that patient has peritonitis? Is that patient has bowel obstruction? Is that patient has intestinal ischemia? Is that patient has ruptured aortic abdominal aneurysm? Or secondly, metabolic causes. Does this patient has diabetic ketoacidosis or acute adrenal insufficiency? So these are the things that you have to consider must while taking history of diffuse abdominal pain, and then if after ruling out these, you will move toward the less common causes that are less dangerous causes. I'm sorry, not less common, less dangerous causes like irritable bowel syndrome. So upper abdominal pain. So if the patient present to you with upper abdominal pain like epigastric pain, right hypochondrial pain, left hypochondrial pain, then you again approach the patient on the same way. You will take the history on same pattern, and then you will examine the patient on the same pattern, and you have some answers on the history and some findings on the physical examination. Then you collect these findings, and then you will construct the differential diagnosis based on that. First thing first, that you need to rule out that whether this patient has MI or not. This is very important thing, especially if the patient present to you with severe epigastric pain, or epigastric pain with anxiety, with sensation of impending doom, vomiting, sweating in the emergency room. Then always rule out myocardial ischemia or myocardial infarction first, then proceed to the other causes, because all other causes are less life-threatening than myocardial ischemia. So first thing first that you need to rule out is MI. If the patient has dull epigastric pain that is not settling, the patient has sweating, patient has anxiety, patient has sensation of impending doom, vomiting, then rule out myocardial infarction first. Send ECG and eye sensitive profile. Second thing that you most commonly encounter in a patient with upper abdominal pain is peptic ulcer disease, that is either secondary to H. pylori or NSAIDs, or due to some dietary causes. So the that particular patient that has underlying peptic ulcer disease will present with some burning, some tearing, some dull epigastric pain, along with abdominal fullness, postprandial blanching, bloating, anorexia, nausea, vomiting. One of the very specific thing that you will ask some patients answer to this question as a yes, some patient no, that the pain, whether the pain subside after taking meal or increase after taking meal. If the patient subsides after taking meal, then the patient might be having duodenal ulcers, and if the patient's pain worsen with meal, that the patient might be having gastric ulcer. So the peptic ulcer disease patients have these constellation of symptoms: the epigastric pain with abdominal fullness, postprandial blanching, bloating, anorexia, nausea, vomiting. What are the red flag signs? You must know what are the red flag signs in peptic ulcer disease. If the patient has weight loss, if the patient has hematemesis, melena, if the patient is looking pale, and he has some iron deficiency anemia underlying, or the patient is elderly, above 50 years, and has new onset of this epigastric pain, burning, then this patient might be having some grave underlying cause like gastric carcinoma, esophageal carcinoma. So if the patient has red flag sign, proceed with the endoscopy, otherwise proceed with the therapeutic trial. Then pancreatitis. The second thing after MI and peptic ulcer disease that he needs to rule out is pancreatitis. These patients typically have severe upper abdominal pain. That might be epigastric, that might be right hypochondrial, that might be left hypochondrial. It can be anywhere in upper abdomen. And the patients sometimes tell you that pain is knife-like and tearing from front to back, and the patients also has complaint of nausea and vomiting. Patient is unable to tolerate any oral intake. So send serum lipase and proceed with CT abdomen pancreatic protocol in that patient. Second thing, pancreatitis, chronic pancreatitis. Abdominal pain may initially be episodic but often become continuous with intermittent exacerbations. Chronic pancreatitis patients have episodic pain. Sometimes pain worsens, sometimes it subsides, worsen, subside, things comes and goes like that. So along with the abdominal pain, patients usually has some exocrine and endocrine dysfunction as well, like steatorrhea, malabsorption, diabetes due to glucose intolerance. So send CT abdomen pancreatic protocol in that patient as well. So if you are suspecting acute pancreatitis, always ask about history of gallstones, any history of alcohol use, any history of drug use like steroids, like antiretroviral drugs, any history of autoimmunity, other autoimmune dysfunctions along with pancreatitis. Ask these questions if you are suspecting pancreatitis in any patient. Then biliary causes. Third thing that you have to consider in upper abdominal pain is biliary etiology. The patient might be having cholecystitis. It's a very common differential diagnosis in patients presenting to you with upper abdominal pain. These patients usually has right upper quadrant pain, but sometimes patients present to you with epigastric pain as well. Such patients also have nausea and vomiting, just like pancreatitis as well. And typically these patients have pain radiating towards right shoulder or back. The most commonest underlying etiology of acute cholecystitis is gallstones, but acalculous cholecystitis can also occur in a very critically ill patients, hospitalized patients. Cholecystitis is third common and very important differential diagnosis in patients with upper abdominal pain. Proceed with ultrasound abdomen and look for gallbladder swelling, edema, pericholecystic fluid, evidence of gallstones in order to confirm the diagnosis of cholecystitis. Second thing is cholangitis, ascending cholangitis that might be secondary to choledocholithiasis, that the patient has gallstones and one of that stone slips and enters into the abdominal bile duct where it obstructs the bile flow and in turns lead to the cholangitis, infection of the biliary tract. The patient typically presents to you with fever, right upper abdominal pain, and jaundice. This triad is very common and presents in 50 to 70% of patients with cholangitis. Again, an emergency, it's a medical emergency. You have to immediately start the patient on empirical antibiotic therapy and arrange for ERC. And then hepatic causes. The patient has fever, vomiting, right hypochondrial pain. The patient might be having acute hepatitis, among that viral hepatitis is very common, hepatic abscess, hepatocellular carcinoma, or congestive hepatic. So fever, vomiting, right epicondylar pain, the patient might be having underlying hepatic pathology. It might be acute hepatitis, hepatic abscess, hepatocellular carcinoma, or congestive hepatic. Order LFTs, order viral screen, including HBsAg, anti-HCV levels, and proceed with ultrasound abdomen to confirm any hepatic abscess, any focal lesions that might suggest hepatocellular carcinoma, any hepatic congestion, or any evidence of hepatic inflammation in acute viral hepatitis. Then these are the four major common components of upper abdominal pain that we have to consider. There are a lot of other causes like splenic rupture, splenic abscess, subdiaphragmatic abscess, and pleuritic pain, along with the differential diagnosis of upper abdominal pain. But these are the four major areas that you have to consider while approaching the patient with upper abdominal pain. First thing first, you have to rule out the myocardial infarction, then peptic ulcer disease, pancreatitis, acute or chronic, then biliary causes that includes cholecystitis, cholangitis, and lastly hepatic causes. These are the commonest and some sort of life-threatening conditions that you have to be taken care of. Then the lower abdominal pain. So what are the red flags in the lower abdominal pain that we have to rule out? First thing first is appendicitis. It's a very common diagnosis in a patient presenting with lower abdominal pain. So the patient usually has perimbilical pain initially, that later on radiates toward right iliac fossa, and the patient usually has anorexia, nausea, vomiting, tenderness, and rebound tenderness by the time the patient is experiencing pain in the right iliac fossa. So if you are suspecting appendicitis, order ultrasound abdomen and pelvis, and if it's inconclusive, go for CT abdomen and pelvis. Second thing is diverticulitis, especially in older people. Diverticulitis is the common differential of appendicitis in the patients presenting with lower abdominal pain. So the symptoms include left lower quadrant pain, that is common in 70% of cases, nausea, vomiting. Constipation is not that much common, diarrhea, and urinary symptoms. So if the patient has, if you are suspecting diverticulitis, the patient usually has severe pain in the right or left lower quadrant. He might be having nausea and vomiting, and sometimes he have constitutional symptoms like fever that shows systemic toxicity, constipation, diarrhea, urinary symptoms. Right-sided chronic diverticulitis is less common, but in Western countries, but it's very common in our setup. So you can present, you can have diverticulitis with presentation exactly like appendicitis. So again, the diagnostic workup we proceed is CT abdomen pelvis with contrast, and we immediately start the patient on antibiotics for both appendicitis and diverticulitis. Then mesenteric lymphadenitis in young adults, it's a very common differential diagnosis of patient presenting with lower abdominal pain. You will get a recent history of viral infection like sore throat, viral stomach flu, viral gastroenteritis, and later on patient present to you with right iliac fossa pain and tenderness. These patients usually respond to antibiotic therapy. You don't need for any particular diagnostic workup for that. Michael's diverticulum. It's a very important differential diagnosis in adolescent age group and childhood age, especially if a young lad present to you with severe lower abdominal pain that mimics appendicitis. Sometimes this patient has bloody diarrhea. So suspect Michael's diverticulum these patients as well. So we usually go for naked scan, but CT abdomen pelvis can also help in diagnosis of this diverticulum. Then in females, you have to keep these four important differential diagnoses in mind. If a young female or middle-aged female, reproductive age female presents to you with lower abdominal pain, first of all, ask about pregnancy. First of all, ask about pregnancy. If the patient is pregnant or if the patient has missed her last menstrual period, check her LMP. If you are suspecting pregnancy and the patient has severe lower abdominal pain and some general bleeding or spotting, the patient might be having reported pregnancy. It's a very important diagnosis of lower abdominal pain in a reproductive age female that must not be missed. So immediately order ultrasound abdomen and pelvis and proceed with the surgical team. Second thing is adnexal torsion, ovarian torsion. Especially if the patients have history of adnexal cyst, that adnexa might twist around its cord or around its axis. So patient presents with sudden onset of severe pain in the lower abdomen along with urinary urgency, nausea and vomiting. So order ultrasound abdomen and pelvis, and if it's inconclusive, go for CT abdomen and pelvis. Third thing is endometriosis. It's a very underdiagnosed condition and very commonly missed in both emergencies and OPD visits. Patients usually presents with episodic pelvic pain, rectal pain, dysmenorias, dyspareunias, pain usually severe before menses and usually begins before menses and then gradually worsens till the menses abates or ends. Sometimes patient remain asymptomatic and presence and or extent of endometriosis does not correlate with the symptoms. Pelvic ultrasound, you will order first order pelvic ultrasound followed by transvaginal ultrasound where you might find a chocolate cyst within menses. Diagnostic laparoscopy is the diagnostic modality of choice in that patients. Then pelvic inflammatory disease, it's also very common underlying diagnosis in females presenting with lower abdominal pain, tenderness, that the pain specifically begins during or shortly after beginning of menses. In most of the patients, pain is accompanied by abdominal uterine bleeding, dysfunctional uterine bleeding. Coitus and sudden movements might worsen the pain. Only 50% of patients are febrile. Usually many patients have very minimal symptoms. Pelvic pain followed by transvaginal ultrasound and treat that patient with broad spectrum antibiotics. Then after ruling out the pelvic causes, especially in females, consider ulcerative colitis if the patient has bloody diarrhea along with lower abdominal crampy pain. Go for stool analysis and calprotectin levels and order colonoscopy with biopsy in that patients. Then lastly, renal causes, genitourinary causes, acute cystitis. So very common diagnosis in females and also in males as well. Patient presents with lower abdominal pain, dysuria, frequency and nocturia. Order urine complete and ultrasound KUB to rule out any renal stone or any other structural anomaly and start the patient on antibiotics. Pyelonephritis, acute pyelonephritis. That patients have features of acute cystitis plus fever, nausea, vomiting and flank pain. Immediately go for ultrasound KUB to rule out any perinephric abscess. Do urine complete and start the patient. Do urine complete and culture sensitivity along with blood culture sensitivity and start the patient on broad-spectrum antibiotics. Nephrolithiasis, flank pain that is colic in nature, radiating towards groin along with urinary symptoms. The patient might be having uteric colic or renal stones. Go for ultrasound KUB or followed by non-contrast CT scan. On ultrasound KUB you will find hydronephrosis, and on non-contrast CT you can find exact location of stone. So this is again a general picture of abdominal pain and their differential diagnosis with respect to each quadrant. For general approach, we have discussed in terms of lower abdominal, upper abdominal and diffuse pain to simplify the things on OPD and emergency level. So how to investigate the patient? This is very important. We have discussed the investigations along with uh, discussing the differential diagnosis. But the important investigations while approaching an abdominal pain that we have to keep in mind. First thing first is plain X-ray abdomen erect, especially if you are suspecting peritonitis, bowel obstruction. Second thing is ultrasound abdomen and pelvis. Again, if you are suspecting peritonitis, you will get free fluid in the abdomen, and if you are suspecting bowel obstruction, you might have exaggerated bowel, distended gut loops before the level of obstruction, and in case of cholecystitis, you can get distended bladder with pericholecystic fluid. So ultrasound abdomen and pelvis is a very useful modality in while investigating the cause of abdominal pain. Then you can order some blood tests to assess the status of the patient, like complete blood count to look for evidence of elevated TLC count that might indicate ongoing infection or inflammatory status, basic metabolic panel to assess for dehydration, renal function, electrolyte abnormalities, C-reactive protein, especially in assessing the patient with appendicitis and pancreatitis. C-reactive protein is very helpful in following the patients with appendicitis and pancreatitis. It will guide us about the severity of the condition. Liver function test if the patient has jaundice, and urine test if the patient has some urinary symptoms, order urine analysis. You might get some hematuria or some pus in urine pregnancy tests in all reproductive age females. Order urine pregnancy test in all reproductive age females. Surgical consultation, especially if you find evidence of any surgical abdomen, diagnostic or exploratory laparoscopy can be done, especially if you are suspecting peritonitis, bowel obstruction, intestinal ischemia, endometriosis, ectopic pregnancy. Then we might proceed with diagnostic or exploratory laparoscopy or laparoscopy. So, if we summarize the whole plan, first of all, you have to memorize the abdominal symptoms. Then you elaborate the abdominal pain through the mnemonic LOKIRA, L for location, O for onset, Q for quality, I for intensity, R for radiation, A for aggravation, then second A for elevation. Third thing, that is the most important thing, that is you have to ask the associated symptoms. You start with the general symptoms, then GI, genitourinary, and specific symptoms. Then you go for the drugs, environmental, occupational, and chemical exposure, endocrinopathies, connective tissue disorders, family histories, and malignancy. Then last thing, you enter all these findings. Either you write them on your board or on your paper or on your notes or on your prescription pad, what positive symptoms you could find on history and what findings you got on examination, and then construct a differential diagnosis. These are the differential diagnoses, that the major differential diagnoses, which are almost 6 to 7 in case of diffuse pain, 4 to 5 in upper abdominal, and 5 to 6 in lower abdominal pain. Memorize these differentials, and then if you find any findings and history and symptoms in the history that leads toward some specific diagnosis, then investigate that diagnosis to confirm it. So this is the whole plan, how to proceed a patient presenting with abdominal pain. Inshallah, we'll elaborate few of the diagnoses in detail in coming lectures. Hope you have learned something today, inshallah. Jazakumullah khair. Thank you very much.